Okay, so said earlier this morning, we're living in an exciting generation. We change the future of cardiovascular disease. If we do it anymore, we will shoot ourselves in the foot. It will be a great life. We will go home and drink coffee, and there will be no more patients. We've cured, treated everybody. But let me just summarize where we are and how we're doing in lipidology. We've got some challenges, I must admit. Of all the stuff that always got me when I was a resident and fellow is to try and understand the pathophysiology. I mean, what does this all mean? What should we look at? LDL, HDL, triglycerides, apolipoproteins. About a year or two ago, so I said, well, this is a whole lot of nonsense. All we have to do is reduce the LDL, use a statin, you've cured the world, we saved the world, finished. And all the rest is nonsense. And we're going to come to in a few minutes what's going on now to say that that's correct. It's great stuff. Well, no doubt about the LDL. But maybe there's some more stuff we have to learn. Second thing is, what endpoints should we look at? Can we use just the lipids or the plaque volume on an IVUS or an MRI or a CT to the extent of disease to guide us in the phases of drug development, or do we need the outcome events? Because that's what matters. And then what is the comparator? And this is the problem with every clinical trial you'll ever do. While you're doing your study of what do you call it now in diabetes that Heinz was talking about, Carmelina, on a DPP-4 inhibitor, here the guys are doing trials at the same time on empagliflozin, which is an SGLT2 inhibitor. And somebody has a quantum leap forward, so you're doing your trial against the old stuff, not against the new stuff. How do you keep pace? And this is a problem for the companies especially. But how do you position your drug in a field against the standard of care? Easy. But the standard of care is not the same standard in another year or two. Okay, let's move ahead. So I'm going to talk about 4 groups of drugs. First is what are the LDL story, what's the HDL story, what's the triglyceride story, which is a big hit for those who looked at ACC were there last week, and some new stuff. Okay, LDL story, we all know it. I'm just going to remind you that this is this classic LDL trialist CTT collaboration from Oxford. What's his name? Colin Bajan's group. The reduction in LDL cholesterol goes with a proportional reduction in events. It's all on the same line. And improve it is shown here in yellow for one good reason, was proved us 2 pathogenetic points. One is that a non-statin can do the same. And secondly, that this was the lower 50 was about the, remember the Venturi said improve it, was better than 70. So the guidelines, current guidelines, are recommending everybody's talking about 70 or 80 or 70 milligrams. The new dyslipidemia guidelines will be different. I'm not allowed to tell you what's written in them. I'm sorry to say, really, they're very strict, but you will hear them in Paris, and it takes into account new studies like Improve It would have taught us new things. Okay, so this is still the LDL story. We all know that the Fourier study reduced down to 30 LDL. There was, again, improvement. It showed, again, we're on the same line. This is a different way of showing it from Mark Sabatine when he showed the Fourier study. These are the 4 quartiles of placebo. These are the 4 quartiles of evolocumab. So you see the curve is consistent and LDL lowering is in to stay. One interesting thing, it may improve death. It depends how long you look and if you look at recurrent events. But there's one interesting thing is maybe the other ways of lowering LDL. And if you look at PCSK9 inhibitor studies, well, you've got to inject that stuff and you give it twice a month or once a month if you follow those trials. But there's other ways of doing it. And now there's a new study of Orion. It's Orion 2 is ongoing already. This was the first study, proof of concept, that inclisiran inhibits PCSK9 synthesis. So instead of inhibiting the PCSK9, you prevent the body from producing a PCSK9, which is going a little bit upstream. I'll tell you what's interesting about this study in a minute, which if you guys don't know it, it's very interesting to me. This is how it works. that there's a whole lot of rationale here, how they build the molecule to have it taken up into the liver, into the proper cells, not into other things. And what's important, this is an RNA-induced silencing complex risk, because there are now other drugs in development using the same principle, that you have a mechanism to get stuff into the cells to silence the RNA. In other words, to interfere with protein synthesis at RNA level. You switch off the RNA and you don't synthesize the protein. That's the importance of this graph. Now, when you do that, you find that in the RN1, one injection lasts half a year. Maybe 2 injections, even more, lasts half a year. So this is now a new concept. So maybe now we have a drug that you know that, how do you like that one? You say, this is my birthday. I'm going in for my annual injection. I'm getting a once-a-year drug. Once a year on my birthday, I'm getting my lipid-lowering drug. Maybe there'll be a drug for glucose stabilizing, my drug for whatever it is, and then I'm going out to the party because I'm protected for the next year. It's a new concept. And basically, even more than that, not I'm doing it, but if you to send your patient for a 6-month thing, you're taking away the responsibility from the patient. You have to be sure that you're doing the right thing. Because if you get it wrong, if it turns out that this is not good, it's going to be not good for 6 months. The side effects might also be for 6 months. Okay. But the concept's an interesting one, saying patients sometimes take their drugs, they don't, there's compliance, this thing. But if you've got a winning drug, I mean, I'd like to do this with a statin, really. Because I think statins really are here to stay. And once every 6 months might be a new way to treat patients. Okay, what else is new? They just studied, there's just been Esperion Therapeutics, bempedoic acid. I've no shares in the company, by the way, it's in any of these companies. But this is another way of lowering LDL. It's more upstream. Here, statins work at HMG-CoA reductase. This drug works up here. There's a short name for citrate ACA, whatever it is. But this bempedoic acid stuff also works. It's for people who can't tolerate statins, maybe. It works as an add-on to statins. There's some studies that showing, there was a study now at ACC also using this drug. And it's maybe an alternative way of lowering LDL. Again, we're on the LDL bandwagon. These are some press releases, which I don't think we need to go into, actually. What I'm saying is that the LDL undoubtedly has changed the way we look at we treat our patients, because we do it to everybody, and there are new standards and new recommendations coming out in the new guidelines, which I think we'd all agree on when we see them. In fact, I think they're too conservative, but I'm a bit crazy. And we have certainly changed the future of patients with cardiovascular disease. So what's the HDL story? Okay, CETP inhibitors, I'm going to talk about epigenetics, and what about apolipoprotein A1 infusions? CETP, there's nothing to talk about. They failed. Torcetrapib had off-target side effects. Dalcetrapib had raised HDL by 25%. The mechanism was wrong. We got the result. We didn't do anything for the patient. This will not be developed, and this was abandoned. So we can forget about CETP. There's a trial ongoing called BET-on-MACE trial. We're doing it. It looks at epigenetics. That means that there's a drug called apabetalone. It's a first-in-class drug. It stimulates changes gene expression, and basically it does that by, in the double-strand helix in the genome, it changes the way the gene, not that it's there, but how much it's expressed. So you get sorry, wrong one. You get a situation where this drug might do, changing the expression of by this drug might reduce vascular inflammation, improve metabolic profile, change reverse cholesterol transport function, and have a positive effect on antiplatelet activity. Now, my instinct tells me that that's too good to be true. Okay. But there's some very smart guys out there who are doing this study. I'm doing the study. I'm on the committee. And I can tell you that we're closing it out in the next, starting, I think, in April, May, June, July. We'll have results possibly in the public domain after ESC, probably, maybe in time for AHA. And you never know. there's a good basis for it, but wait and see. The last thing I want to tell you about HDL and reverse cholesterol transport, which means getting the cholesterol out of the plaques, is the AEGIS program run by Mike Gibson of Boston, the Perfuse study. And this is in animals. It shows this is placebo and this is the drug. This is placebo and this is drug. What happens is these are the plaques, the red stain plaques, this is the drug. These are the plaques, this is the drug. So when Mike Gibson says, and I'm giving him full credit for it, it's like liposuction, sucking the fat out of the plaques, or it's like vacuuming out the bad stuff out of your arteries, and because you increase cholesterol transport out of the plaque by infusing human-derived apolipoprotein A1. Now, there have been some other studies looking at Milano and other things, but if you talk to the experts, which I have, but if you understand the experts, which I have not, but they still show different graphs explaining why that did not work and this may work. So right now, ongoing is the AEGIS study, which is randomizing 17,000 patients to 2 arms, and there's already about 10% enrollment. It's only started in the last 6 months. 10% enrollment, 1,700 out of 17,000. The idea is this. You recruit people who've got an acute coronary syndrome, AMI. It could be ST elevation MI, non-ST elevation MI. But usually what we've learned is, and from a lot of trials, that you have one event, you have one bad artery, but the other's also not so good. You've got plaques everywhere, and there may be an inflammatory state. We've all heard Paul Ritke about the anti-inflammatory test, the Cantos, all other things going on. But we all know that recurrent events are very common soon after an MI. Now, by the time the statins work and kick in and the other lipid lowerings work, that's a few months. So this study is looking at 4 infusions, 1 a week, immediately after MI. The mean inclusion is within the first week starting infusion number 1. After the patient's had a PCI, after he's had all the treatments been stabilized, but instead of just sending home on the usual statin drug, we do that, but we add in an infusion of this substance versus placebo. And the idea is that within the first 6 months, we're going to see a change here in the early recurrent event rate. That's the hope. Okay? The study primary endpoint says 6 months, following the patients to 12 months to see if there's a sustained event, if there's an early event. So that's APA-A1 infusions. It's called the AEGIS program. We're now on AEGIS II is the phase 3 randomized trial. Triglycerides. I really thought triglycerides were out. I was telling my patients that, in the age where we've got great lipid lowering with LDL lowering, we don't really have a good drug for triglycerides. You can do diet, you can do everything else, but the added value you're going to get here is not so great. And I don't have anything that's impressive to treat you with, because we don't. We have it. Bezafibrate, maybe not. All the other stuff has not really worked out. So I was trying to make my patients psychologically feel happy by telling them that there's not much you could gain. And then very recently, you always get surprises. Some guys come up with this data, a guy called Gregory Nichols, showing that for people with high versus normal triglycerides, above 200, versus normal, less than 150, despite all the best treatment with all the other stuff, including great treatment with statins, you look at the event rates, the high triglycerides do worse on everything you look at. They have more non-fatal MIs, more strokes, more unstable angina, and more need for coronary vascularization. So there still is a factor that triglycerides are still a risk factor, no matter what I said. And all I said was to make the patients happy, we have nothing to treat it, but the message is maybe we do have something to treat it. So the REDUCE-IT study, which was shown last year at the AHA in Chicago and again at ACC last week in New Orleans, looked at people who are optimally treated on their LDL, but do have a fasting triglycerides above 135 and up to 500. So the mean on this arm of triglycerides is about 240 on entry. It means not people with normal triglycerides, but people with elevated triglycerides. And then they're randomized to the icosapent ethyl, which is called Vascepa, 4 grams a day, high dose, purified substance, high dose, versus placebo. And we all know that the primary endpoint was met. There was a huge reduction in death, MI, stroke, vascularization, or the key secondary endpoint, which is the triple death, MI, or stroke, by about 25 or 26%. And the question I asked is, why does this fish oil work? Because we've done this before. There were a number of studies. We did the Origin study. The Origin study is diabetics who had Lantus insulin. We showed that it didn't do harm, it did blah, blah, blah. But there was also a 2x2 factorial design in Origin, which gave quite high dose omega fatty acids and showed absolutely zero effect. So when this came out, I went back and looked up Origin, and what did I discover? That in Origin, the mean triglycerides were really not elevated. 130 was the mean, whereas here the mean is 250. So what I'm saying is, if you take people who don't have the risk factor, their triglycerides are normal, if they don't have the risk, it's hard to make them survive. Kurs Lapshin, who was my first teacher in epidemiology and clinical trials, said, you can't save a person who's not in danger. If a patient is not going to die now, you're not going to save his life, because he's going to live anyway. So that's what's been going on the previous trial, and maybe there's something in it, and Vascepa maybe has a real message. Now, to amplify the message, I just want to point out something else that I think we need to learn about clinical trials, and somebody talked about this earlier, or was it Giuseppe Rossano, I think maybe. But if you look at the data I showed you, that's the first event. This is the drug, this is placebo, 0.75, 25% risk reduction. You guys with me? But if you look at recurrent events, and I'm jumping to the first recurrent event, the second recurrent event, the third and the fourth recurrent event, you see that it's kind of like exponential logarithmic. So if you look at the total burden of ischemic events, I shouldn't say ischemic events, maybe it is, but the total burden of endpoint events, the total burden of endpoint events versus the total burden of endpoint events on placebo versus the drug, you have a much bigger effect. And this principle of looking at total events, I think, is so obvious when you think about it. I don't know why we don't do all trials like this, but I'll give you another example. If you do a trial on antiarrhythmics, and what's the best drug to prevent recurrent atrial fibrillation effectively, as far as I know, maybe I'm wrong, you guys correct me, a good drug is old stuff, amiodarone. Amiodarone has a bigger effect, about 70% relative risk reduction. But amiodarone doesn't kick in. So if you do a trial with propafenone and versus amiodarone, you might find that the first event you'll get with amiodarone faster than with propafenone. Propafenone works quickly. Amiodarone takes till you build blood levels, it depends how you dose it, till you fill the body stores. But if you want to know what's better for the patient, look how many episodes of AF he has in the next year or two. So you need total events. This is what bothers the patient more than the first event, which bothers the company or the scientist. So this is just an interesting point I'm bringing in here. But the point I think we're talking about lipids, maybe triglyceride lowering is really a big deal. This is the same thing graphically. This is if you look at all events. This is if you look at just the first event. You see how you amplify the effect with the more events that you're preventing. Now, I hope there's another study coming up with a drug called Epanova from, I believe it's AstraZeneca. Again, I have no shares in the company. It's another fatty acid based on placebo control with corn oil, because there's some criticism of the reduced study of their placebo. So here's another company looking at a different placebo, and hopefully later in the year we may have another drug that again is targeting people not just generally to lower triglycerides, but people who really need their triglycerides lowered. Last thing about triglycerides, we're in the middle of doing the prominent study. And this is a drug that's looking at pemafibrate, which is an improved version of bezafibrate. Now, pemafibrate has much greater potency and PPAR alpha selectivity than fenofibrate, which is bezafibrate. It has about 30 to 40% better lowering of triglycerides and is supposed to be more effective. So again, we're in the middle of the trial. It's a 10,000 patient trial, pemaferbit versus placebo. In the study, they're watching the patient's LDL, and all the other stuff has to be treated with the best available therapy, meaning at least moderate to high dose statins. Everything's watched and monitored. And on top of that, as I showed you in one of the first graphs, can you actually prevent the extra events that high triglycerides make you liable to? So all I can tell you is watch the study. This is where we are now, 6,000 out of 10,000. It's going to be another year or two before we have results. That's the triglyceride story. There's still some thing we need to learn here. The last thing I want to share with you guys is something we learned from you people familiar with the thing about the genetic work of Brian Ferenc and various other people looking at the natural Mendelian randomization. If you look at people with genes have different, we all have different genes. From that, you can look at population studies to see the propensity to disease. And there's genes and PTL3 and PTL4, which if you've got the right genetics, you have a much lower incidence of coronary disease and type 2 diabetes, irrespective, by the way, if you have genetically high LDL or genetically lower LDL. Okay, so it's a different pathway. Despite your because if you look at LDL, if you've got genetically higher LDL, you do worse than genetically lower LDL. So it shows that despite that, now here's another new pathway, and this stuff interferes with the lipoprotein lipase pathway. I hope I have a slide of that somewhere. Yeah, so if you have this deficiency in your genes, you're protected from coronary artery disease. Now, what the ANGTLD pathway does is it interferes with the lipoprotein lipase pathway. It makes the inhibitor of lipoprotein lipase, kind of blocks it. So you have more lipoprotein lipase. If you have more lipoprotein lipase, you metabolize your triglycerides and your fat lipid metabolism better. That's how you remember it. Lipoprotein lipase is a facilitator of metabolism of a lot of the lipid metabolism. So there's some evidence from the genes, there's some evidence from the blood levels, there's some evidence of knockout mice or genetically engineered animals, and there's now some breakthrough designation given to this drug by the FDA to move it ahead. It's called evinacumab. It's an antibody, which is a monoclonal antibody to PTL3, as I said, an inhibitor of lipoprotein lipase, means your lipoprotein lipase goes up. And this drug's been pushed quite well. It's actually, as you'd expect, it reduces triglyceride levels hugely by 60 to 70%. Regeneron, which is a company that's developed it, the Regeneron guys from a whole lot of other stuff, starting with TPA. They have a trial in homozygous familial hypercholesterolemia, again, where we don't have great answers. And it's a totally new pathway, which we're going to have to watch. I'm sure there are a few other areas of new lipid research that we're going to have to watch, but I don't know more about them, and we run out of time. So thank you very much.